Welcome back to Roadmap to Residency. Today we're attacking urinary tract issues on Step 3, the way the exam actually tests you. We won't reteach nephrology and infectious disease. Instead, we'll look at the exact stems you'll meet on test day, the words the writers plant to steer you, and the reasoning that gets you to the answer fast. Keep your question bank and a trusted review resource beside you. Let's begin. Here's our roadmap. First, we'll separate a bladder infection from a kidney infection using clues in the stem, because the exam rarely gives you the culture before it asks. Second, we'll handle bacteria in the urine without symptoms, one of the most reliably tested and most missed topics. Third, we'll build fixed decision pathways for recurrent infection and blood in the urine. Along the way, we'll work through practice questions and explain why every answer choice is right or wrong. Our job today is to sharpen how you take the test. Strategy 1 is placing the infection anatomically before you touch an answer choice. Burning, urgency, frequency, and low pelvic pain with no fever describes a simple bladder infection. The moment the stem gives you a temperature, chills, vomiting, or flank tenderness, the infection has climbed to the kidney. Notice the exam signals this jump with a temperature and an exam finding, not a lab value. Now let the stem choose therapy. A bladder infection in a healthy non-pregnant woman gets a short oral course with no culture and no imaging. A stable kidney infection patient who can keep fluids down still goes home on oral therapy. Save the intravenous answer for the patient who is vomiting, unstable, pregnant, or who has failed outpatient treatment. Most students lose this by reflexively admitting a patient who never needed a hospital bed. Strategy 2 is bacteria in the urine without symptoms, where the exam harvests points from good students. The default answer is no treatment. Picture a nursing home resident, a patient with a long-term catheter, or an adult with cloudy foul urine and a positive culture, but no burning, urgency, or fever. That patient needs no antibiotic. Watch the confusion trap. An older adult who is a little confused, with a positive culture and no urinary symptoms, is not a urinary tract infection. Observe and look for another cause of the confusion, such as a medication, dehydration, or another infection. Now memorize the 2 exceptions. First, pregnancy, where untreated bacteria progress to kidney infection and preterm birth, so you screen and treat. Second, a patient scheduled for a urologic procedure that breaks the lining of the tract, treated beforehand. Every other patient is left alone. Strategy 3 is reading the stem for the clues the writers planted. First, the fever sentence decides the diagnosis. Before you look at the choices, scan the vitals and the flank exam. A normal temperature with low pelvic discomfort keeps you in the bladder and a short oral course. A temperature with flank tenderness moves you to the kidney and stretches treatment to roughly 1 to 2 weeks. Second, the pregnancy sentence overrides everything. The word pregnant, or a stated gestational age, rewrites the question. It forces you to treat bacteria you'd otherwise ignore and removes several antibiotic choices. Hunt for it before you commit. Third, the catheter and nursing home sentence is a trap. That's usually a bacteria without symptoms question in disguise. Go looking for a real symptom. If burning, urgency, fever, and flank tenderness are all absent, withhold antibiotics and look elsewhere. Let's work through our first practice question. A 24-year-old woman who is not pregnant comes in with 2 days of burning, urgency, and frequency. She has no fever, no back pain, and no vaginal discharge. Her temperature is normal, with no flank tenderness. A dipstick is positive for leukocyte esterase and nitrites. What is the most appropriate next step? Notice what the stem gave you and what it withheld. She's young, not pregnant, afebrile, and her flanks aren't tender. Read the 4 options, commit to an answer, then we'll walk through the reasoning. Let's break this down. Step 1. Spot the pattern. A healthy non-pregnant woman with burning, urgency, frequency, a normal temperature, and no flank tenderness. That's a simple bladder infection, and the positive dipstick just confirms it. Step 2. Apply the rule. It's a clinical diagnosis treated immediately with a short oral first-line agent such as nitrofurantoin. No culture, no imaging. Step 3. Eliminate the wrong answers. Choice A. Getting a culture and waiting. Delays therapy for a diagnosis you can already make. Choice C, CT of the abdomen and pelvis, is the classic overkill trap and would change nothing. Choice D, admitting for intravenous ceftriaxone, is far too aggressive for a well-appearing outpatient. The correct answer is B, a short course of oral nitrofurantoin. Here's our second practice question, testing whether you can move the infection up the tract without overreacting. A 32-year-old woman who is not pregnant has 2 days of burning, followed by 1 day of fever and right-sided back pain. Her temperature is 38.6 degrees Celsius. Blood pressure and heart rate are normal. She has marked right flank tenderness. Importantly, she's drinking fluids without difficulty and has not vomited. What is the most appropriate next step? 2 details are doing all the work, and 1 is easy to skim past. Pick your answer and we'll reason through the options. Let's work through this. First, move the infection upstairs. Fever plus flank tenderness, after 2 days of bladder symptoms, tells you it's reached the kidney. Here's the distinction the last question set up. Unlike a bladder infection, a kidney infection does get a urine culture because you'll need the organism and sensitivities if she fails to improve, and the therapy is longer. Second, stable means oral therapy. Her vitals are normal, she's keeping fluids down, and she's not pregnant, so treat her at home with an oral agent and close follow-up. The correct answer is B, obtain a urine culture and begin oral ciprofloxacin as an outpatient. Now, the wrong answers. Choice A, 3 days of trimethoprim sulfamethoxazole treats a bladder infection and is far too short. Choice C, admitting for intravenous antibiotics and scanning, is the overkill trap. Imaging is reserved for the patient who fails to improve after 2 to 3 days, or when a stone or obstruction is suspected. Choice D, withholding antibiotics, would be dangerous in a febrile kidney infection. Now let's build a fixed pathway for blood in the urine. First, ask whether the blood is real. A dipstick positive for blood means nothing until microscopy confirms red cells. Muscle breakdown after intense exercise, menstruation, and certain foods and medications all light up a dipstick with no red cells present. If there are no red cells, this isn't a hematuria question, and the answer usually involves recognizing the imposter. Second, ask whether there's a reason. If red cells are present, look for an explanation the stem handed you. Painful bleeding with severe flank pain in waves points to a stone. Bleeding during an active infection points to the infection. Bleeding after vigorous exercise points to exercise. Treat the cause first, then recheck the urine. Now the pattern that carries the most weight. Painless bleeding with no explanation in an older adult who smokes is cancer until proven otherwise, and it demands a full workup with imaging of the upper tract and visualization of the bladder. The smoking history is the single most reliable clue. Highlight it every time. Here's our third practice question. The highest yield stem in this lesson. A 68-year-old man comes in after his urine turned red twice last week. He has no pain with urination, no fever, and no back pain. He smoked 1 pack daily for 40 years. Vital signs are normal, exam unremarkable. Urinalysis shows many red blood cells, no white cells, no bacteria, and no casts. What is the most appropriate next step? Every clause was placed on purpose. Note the age, the absence of pain, the smoking history, and that the urinalysis rules out infection and kidney inflammation. Choose your answer, and we'll reason through the options. Let's break this down. First, name the planted clues. Painless bleeding, an older adult, and a heavy smoking history are the exam signature of bladder cancer. Then notice the urinalysis. Many red cells means the bleeding is real. No white cells and no bacteria removes infection. No casts removes kidney inflammation. The writers cleared the field, so 1 diagnosis remains. The correct answer is C. Image the upper tract and refer for cystoscopy, because you evaluate both the upper tract and the bladder. Now the wrong answers. Choice A, reassurance with repeat testing in 6 months, is the most dangerous option, because it delays a cancer diagnosis in the exact patient most likely to have one. Choice B, antibiotics, treats an infection the urinalysis already excluded. Choice D, a 24-hour urine protein collection, chases kidney disease, but this patient has no protein and no casts. Here's a critical pearl on recurrent infection. On your first pass, count and confirm. Recurrent means 2 or more infections in 6 months or 3 or more in a year. Before you accept that label, verify each episode was a true symptomatic infection with a positive culture, because bacteria without symptoms don't count and never needed treatment. The writers love to inflate the count with cultures from a patient who felt fine. On your second pass, choose prevention over imaging. For a healthy woman whose infections follow intercourse, the highest yield answers are behavioral counseling, a single dose of antibiotic after intercourse, or a self-started course she initiates at the first symptom. All three keep her out of the radiology suite. Imaging and urology referral are reserved for a stone, obstruction, the same organism persisting despite therapy or infection in a man or child, where any infection is abnormal until proven otherwise. That wraps up urinary tract issues for Step 3. Remember the core ideas. Place the infection anatomically before you look at the choices, because fever and flank tenderness separate a bladder infection from a kidney infection. Treat a bladder infection immediately with a short oral course and skip the culture. Culture the kidney infection, but keep the stable patient home on oral therapy. Leave bacteria without symptoms alone unless the patient is pregnant or heading for a urologic procedure. Handle recurrent infection with prevention, not imaging. And when you see painless blood in the urine in an older adult who smokes, image the upper tract and look inside the bladder. Lock this in by drilling the infectious disease and nephrology sections of your question bank under timed conditions. Visit roadmaptoresidency.com for expert tutors and advisors. If this helped, please like and subscribe. Good luck on your exam, and we'll see you next time.